Azad National Urdu University. It's an honor for me to welcome you all in this two-day international seminar on politics of gender, health, and digital initiatives in India. Today marks the second day of our seminar, and we are excited to continue the rich academic exchange that began yesterday. I hope today's session will further deepen our understanding and stimulate critical reflection on the intersection of gender, health, and digital policy in the Indian context. In continuation of our enriching discussion, I'm pleased to begin today's session. In today's session, we have six speakers with us who will shed light on different important topics. Our today's session will be chaired by Professor Mateen sir. I humble request sir to please rise. Yeah. So let me take a briefly introduce to chair of our today's session. Professor Abdul Mateen sir is an eminent sociologist and currently visiting professor at the University of Science and Technology, Meghalaya. Formerly professor and chairperson at the Department of Sociology, MU, Aligarh, and director of CCP at MANUU, Hyderabad. Sir has over 29 years of academic experience. Sir has published 20 books and 40 research papers and edited the Journal of Exclusion Studies in 2011. Sir research span digital sociology, health, social exclusion, agrarian structure, and informationalism. Recipient of the Canadian Commonwealth Scholarship, Sir has contributed including 8 funded research projects by UNICEF and UGC. Sir has actively engaged in scholarly discourse through lectures and national and international conferences. Now it's over to you, sir. Mike. Mike. Yes, sir. एक mic. Yes. Schedule. Yes.
I think we have 6 papers, so those offline, why not they should be requested to join. The website is Varsha Kaur, Shabana, then Dr. Shabana Kaisar, then Pratibha Desai, and Reshma Sawan. Please join. However, we start with we'll start with online first. So, in digital, probably differential treatment to digitize, so online. What a coincidence! So, first one is Shazia Chaudhary online. The topic is digital inclusion and travel movement in Jammu and Kashmir. The case is study of Gujarat and Pakarwan travel movement. So over to Shazia Chaudhary online.
Good morning, all of you. Am I audible?
Yes, you are audible. Please go ahead.
Okay. Myself, Shazia Chaudhary from Jammu and Kashmir, and today's my topic is digital inclusion among tribal women of Jammu and Kashmir, a special study of Gujar Bakarwal women. So I try to share screen.
I think we have 6 and total time, maybe 8 minutes presentation and 2 minutes question answer. So, and what I prefer that maybe that immediately after the paper is over, one can have quick observation question if needed, and then we go to the next one. So, yeah, Shantanu, you may start, and you have 8 minutes, and unfortunately after 7 minutes I will end or I will interrupt.
Thank you, sir. This study explores the digital inclusion of tribal women in Jammu and Kashmir, focusing on the Gujar and Bakarwal communities in Rajouri district. Despite the transformative potential of information technology for education, economy, and governance, tribal women face significant digital exclusion due to remoteness, illiteracy, and lack of access. The Digital India initiative aims to bring this gap, yet marginalized groups remain undeserved. Gujars and Bakarwals, J&K's third largest cultural group, led nomadic lives with women bearing a heavy physical and emotional burden. These women perform household chores, care for livestock, and endure early marriage, poverty, and social inequality. Their hard life leaves little time for self reflection or empowerment. Despite their vital role in tribal society, the study based on primary data highlights their challenges and the urgent need for digital access to improve their lives. Next, Jammu and Kashmir, India's northmost region, nestled in the Himalayas, has a rich history shaped by the Mauryas, Mughals, and Sikhs. After India's independence in 1947, the princely state acceded to India on October 26 through the Instrument of Accession. On August 5, 2019, it was reorganized into two union territories, Jammu Kashmir and Ladakh. The region borders Pakistan, Ladakh, Punjab, and Himachal Pradesh and is home to a diverse ethnic mix. Among its major groups are the Gujars and Bakarwals, recognized as scheduled tribes since 1991, forming the third largest ethnic group after Kashmiris and Dogras. Gujars, believed by some historians to have migrated from Central Asia via Gujarat and by others as native Kshatriya, moved through various Indian states before settling in J&K. Gujars and Bakarwals share identical ethnic, linguistic, and cultural traits, with Bakarwals historically identified by their pastoral occupation of rearing sheep and goats, while Gujars typically own agricultural land and cattle. They now make up about 20% of J&K's population, over 11 lakh people as per the 2011 census, and inhabit almost every district, especially mountains and forested areas. Traditionally semi-nomadic, they follow seasonal livestock migration, living in harmony with nature. Their forest-based lifestyle keeps them close to biodiversity, earning them the titles Lords of the Woodlands and Children of Nature. Strongly depend on pastoral livelihoods, their physical endurance is shaped by the tough terrain and nomadic life they lead. Gujar Bakarwal women and tribes in Jammu and Kashmir. The Gujar and Bakarwal tribes, primarily pastoral and transhuman, migrate year round across the Himalayas in search of grazing land. Their shelters of deras made from natural materials are temporary and dismantled as they move. Women in these tribes face extreme hardship marked by poverty, illiteracy, early marriage, superstition, and an exhausting nomadic life. They work longer and harder than women of other ethnic groups in JNK, yet remain undervalued and overburdened with domestic tasks, livestock care, and farm support. They often walk long distances with children and belongings, preparing meals and repacking with each relocation. Despite their labor, tribal women face low status in the community and limited access to education. The 2011 census shows a scheduled tribe ST literacy rate of 50.6%, with Gujars and Bakarwals significantly below average. Male literacy is 60.6, while female literacy lags at 39.7%. The 2021 Transhuman Survey revealed a mere 16.74 literacy among 6.12 lakh nomads, with female literacy just 14.8%. Jammu and Kashmir hosts 12 notified ST, including Gujars and Bakarwals. Its most populous tribes along with Balti, Jeda, Bokra, Kaddi, Sipi, and others. In 1991, Gujars and Bakarwals were granted ST status in 2024. The ST list was expanded to include Pahadi ethnic group, Padri tribe, Koli, and Gadda Brahmin under a new constitutional amendment, while Gujars are semi-settled and raise cattle. Bakarwals are fully nomadic, rearing sheep and goats, both speak Gojri and practice seasonal migration. Sharing ancestry and cultural, they are treated as one social group in policy and research. Objectives of the study. The study tries to cover the following objectives: to study the awareness level of tribal Bakarwal women regarding various digital platforms and technology, to study about the use of various digital devices and technology among tribal Gujar Bakarwal women, to understand the problem of using digital devices among tribal Gujar Bakarwal women. Methodology. The study is based on primary data collected from Gujar Bakarwal women in Rajouri district of Jammu and Kashmir UT. Using a purposive sampling technique, 120 women were selected from panchayats Agrati South and Dhada Samla in Block Dungi. Data was gathered through a structured questionnaire and basic statistical tools were applied for analysis. Data analysis and discussion. Demographic, socio-economic, educational, and economic educational and economic profile of the respondents. इसमें मैंने जो respondents हैं उनकी जो एज है 20 to 40 में कितने फॉल करते हैं, 40 to 60 में कितने हैं, above 60 कितने हैं, और मैरिटल स्टेटस में इसमें जो रिस्पोंडेंट्स हैं वो मैरिड, अनमैरिड और सेपरेटेड, डिवोर्स्ड कितने हैं, विडो कितने हैं, ये आप इसमें क्लियरली देख सकते हैं. मैं चाहूँगी कि आगे एनालिसिस में इसका पूरा वो बताऊँगी. एजुकेशनल क्वालिफिकेशन में नो फॉर्मल एजुकेशन, जो इन 120 वुमेन में 11 ऐसी वुमेन है जिन्होंने एजुकेशन ली ही नहीं है. अप टू 8th क्लास 46 हैं और अप टू 10th क्लास 22, अप टू 11th 21, डिग्रीज एंड अबोव में 14 and diploma and other 6.
Sorry for interruption, but can you wind up in a minute? Major findings?
जी, yes sir.
Please summarize your main findings in a minute.
Okay sir.
You have 1 minute left to wind up, okay?
Oh.
आप 1 मिनट में जो मेन फाइंडिंग है ना उसको आप शेयर कीजिए.
जी सर, ओके. The socio-economic and demographic profile of Gujar Bakarwal women in Rajouri district reflect their standard of living, education, social position. Most respondents belong to the working age population. 55% are aged 40 to 60 and 30% fall in the 20 to 40 age group. About 63.3 are married. Educational attainment is low. Only 17.5% studied up to 12th standard and just 11.6 hold degrees or higher qualifications despite government efforts to promote tribal education. This educational gap mirrors their employment status. Only 6.6% are employed in the government sector while 75% work as agricultural laborer. Their nomadic lifestyle focused on rearing cattle, sheep and goats further limits stable employment opportunities. The income data reveals that 85% of households earn less than 6,000 per month in the context of rising prices. Such low income severely hampers access to basic amenities, reflecting the persistent marginalization of these tribal communities.
Have you finished?
Digital inclusion among Gujar Bakarwal women in Rajouri district is limited by geography, lifestyle, and infrastructure gaps. While 85% of respondents own a mobile phone, only 38.3 have internet access in their devices. Primarily through mobile data, most live in remote, Kandi and hilly areas with poor road connectivity and no mobile towers or electricity, especially in dogs, meadows, where nomadic families migrate seasonally with their livestock. Due to the absence of stable network, many rely on mobile recharge shops for data, and internet usage remain low. Among the 46 women participating in digital social groups, only 20% are active, mainly on WhatsApp. For accessing online services, 33% use mobile phones, 61.6% depend on digital centers, and only 5% use internet cafes. Those without mobile internet rely heavily on external centers, but more transport and communication further restrict poor transport and communication further restricts access to these facilities, highlighting the digital divide faced by this nomadic tribal community.
Finish.
Awareness of digital devices and services significantly influences their usage. Among Gujar Bakarwal women in Rajouri, awareness and usage remain low, primarily due to poor education and limited income, while over 50 to 60% are aware of popular platforms like WhatsApp and Facebook.
Shazia, sorry for interventions. I'm afraid I have to ask you to stop now. हाँ, आप क्या ये बता सकती हैं कि ये जो मोबाइल यूज है आपके इस आपके जो स्टडी एरिया उसमें क्या मोबाइल स्कूल है? इट हैज अ डिफरेंट मीनिंग. मोबाइल स्कूल है ये बकरवाल और गुजर्स के लिए? यस और नो?
यस सर, यस सर, मोबाइल स्कूल्स हैं जो डोक या मीडोज में जाते हैं, सीजनली माइग्रेट करते हैं, लेकिन एक्चुअल में वो जो है वो वर्किंग में नहीं है.
मेरा मेरा सवाल ये है आपसे कि आपके स्टडी के बेसिस पे ये जो मोबाइल स्कूल है इट हैज अ डिफरेंट मीनिंग. मोबाइल स्कूल के लिए मोबाइल का यूज किस हद तक मुफीद है या लोग कर रहे हैं? क्या इस पर कुछ रोशनी डाल सकते हैं? आपको 30 सेकंड का टाइम दिया जा रहा है. 30 सेकंड के बाद दूसरा स्पीकर आ जाएगा. प्लीज बियर विथ मी.
सर, मैं आपका क्वेश्चन नहीं समझ पाई. आप क्या कहना चाह रहे हैं? मोबाइल स्कूल एंड मोबाइल फोन का आप क्या रिलेशन?
मोबाइल स्कूल के में जो बच्चे हैं क्या वो मोबाइल स्कूल में रहते हुए ये मोबाइल जो है उससे भी कुछ फायदा उठाते हैं एजुकेशन के पर्पस से?
नो सर, वहाँ पे क्योंकि वहाँ पे इंटरनेट एक्सेस ही नहीं है, वहाँ पे वो नहीं उससे फायदा उठा सकते हैं.
ठीक है, let us wait for Elon Musk to introduce the Starlink and then we will have better technology. Thank you, Shazia, for your interesting presentation.
Thank you, sir, for giving me such a.
Now we will move to the next presenter, Dr. Bhanu Pritam and Dr. Josna Kirti. The title is Health Capital, Women Empowerment and Higher Education, Isata of Madhya Pradesh and Bihar. Over to Dr. Bhanu Pritam, online. Dr. Bhanu Pritam and Dr. Josna Kirti, am I audible? Can you hear me? Unmute, please. You are not audible. Unmute.
Hello.
Yeah, now you are audible. Please start. You have 8 minutes and then it will start ringing. The moment you hear a ring, stop. Okay? Thank you.
Okay. Thank you, sir. So first of all, good morning to all the dignitaries there. And myself, Dr. Bhanu Pritam, and my co-author is Dr. Josna Kirti.
morning, sir. I am Jyotsna Kirti, Assistant Professor from Patna University.
Sir, uh, the topic for my study and which I'm going to present here is impact of financial assistance on doctoral research on women empowerment with special reference to Madhya Pradesh and Bihar. So here I have tried to gather three different indicators, that is health, then women empowerment and research education. Three different indicators I have taken to study this particular research. And especially I have added here health capital into my existing research, which was part of my ICSR project. And therefore, I'm going to begin with the status of health capital in especially the underdeveloped states, and the typical name of these states were the Bimaru states. This is also part of my study, under which I have taken the health status of Madhya Pradesh, Orissa, Bihar, Rajasthan, and Uttar Pradesh, and with special reference to two states which is part of my study, that is Madhya Pradesh and Bihar. Uh, if we look at the status of health in India from three different sources of government documents, that is multidimensional poverty index, to school education quality index, and state health index, developed by Niti Aayog in 2021-22 and 22-23. Looking at these data, we can easily interpret that the status of health, education, and women empowerment or gender parity, gender equality is comparatively low, or you can say lowest among these five states, on which I have specifically studies on two states, that is Madhya Pradesh and Bihar. If HI index is health index ranking. And this ranking shows that out of all these 21 big states, Madhya Pradesh ranks 17, Orissa 18, Bihar 19, Rajasthan 20, and Uttar Pradesh 21. In terms of sex ratio, also we can find that Madhya Pradesh ranks among 7, Orissa 4, Bihar 10th, Rajasthan 16th, and Uttar Pradesh 18th. So these two data sources try to interpret the status of health in India, especially in these five states, which is also named as Bimaru states. So this is about the health capital. Then, as a part of my ICSR research project, I have tried to correlate women empowerment and higher education, and how financial assistance plays significant role in women empowerment, especially at doctoral research and higher education. And I have taken total 6 different dimensions: political, economic, educational, socio-cultural, psychological, and fellowship related. So out of these 6 dimensions which I have studied, I have found that almost all dimensions except the economic one shows that there is a significant relationship between financial assistance and higher education. And here I have studied for women, girl children or girl child of women. So therefore we can say that there is a significant relationship between financial assistance, either by the central government or by the state government, with higher education and research education, as far as gender, women gender, female gender is concerned. Then again, the further bifurcation which I had undertaken in my research, that social bifurcation according to the social categories, that is unreserved category, OBC, SC, ST, all these categories. Here also we found that in both the states, there is a significant relationship between financial assistance and women empowerment as far as doctoral research and higher education is concerned. Here it is important to mention that it is not only the marginalized community, even female from non-marginalized community are staying, or they are living in such a condition that as far as UG education is concerned, that is fine. Family supports there also. But when it comes to postgraduate and doctoral research education, then financial assistance is required, even with the students, female students from the unreserved category. So this was another finding. This is about the gender parity index for 10 years, 2012 13 to 21 22. And here we found that in terms of gender parity index, Bihar is performing a little lower than the index of Madhya Pradesh in terms of gender parity. There is a high gender parity in Madhya Pradesh, especially in the recent years of 2020 21. Whereas if we look at the data from Bihar, Bihar's data show that they have almost stagnant condition in terms of gender parity index. Let us look at the data from gross enrollment ratio in higher education. And we found that among these two states, as far as gross enrollment ratio is concerned, in Bihar, the males enrollment is comparatively higher than the female enrollment. In the same fashion, you will find that the male enrollment in Madhya Pradesh is comparatively higher than the female enrollment in higher education. Here, I want to especially say or point out that as far as national data is concerned, overall data and across the discipline, here I have studied only social science, arts, and humanities. And if we look at the data sources from across the discipline, across the institution, and for national level, then we find that female are performing or their enrollment is comparatively higher than the male enrollment, especially if we look at the social science, arts, humanities. But when we integrate science, technology, everything, then we find data that male enrollment is little higher than the female enrollment in higher education across the years, especially during last 2020-21. As far as the enrollment at PhD level is concerned, here we find that it is not very satisfactory. Almost half of the males population go and they enroll at PhD level, and this data is only meant for enrollment. When we look at the data from the completion of PhD program, then we find that there is a high dropout rate among female as far as completion of PhD is concerned. So the data which shows that about 40% or 33% students are being enrolled from female sections of the society in research education. This
May
is
I
just
request you
enrollment
to
data, and
wind
when
up
you
in
move to
1 or 2 minutes,
completion
please?
data, then further it goes down somewhere around 20%.
Sorry for interruption. Sorry for interruption.
Then social category wise data I have
In 1 or
also
2
shared
minutes.
for higher education across the year. And here, fortunately, we find that open category, general category, SC, ST, OBC, almost everywhere as far as higher education is concerned. And this data is from undergraduate education only. So undergraduate higher education is concerned, then almost across the category, the enrollment is somewhere around 40 to 50%. Then the state-specific data from the Madhya Pradesh also shows that roughly it is about 63% among all the categories, open categories. Then gradually among scheduled caste, males enrollment is little higher, 60%, whereas female 39% only. So looking at the overall data from the recent years, we can find that as far as social categories are concerned, especially scheduled caste, scheduled tribe, and OBC, then among female we find there are lesser enrollment.
Dr. Bhanu Pritam, can you summarize in few sentences about the
Can
major
say
findings
that
of
there is a
your
significant relationship between health, higher education, and women empowerment in India in general, and Madhya Pradesh and Bihar, two states in particular. But when it comes to the data from marginalized communities among these two states, then we find that there is little sorry state of affairs among the marginalized community women in terms of higher education and research education, and therefore financial assistance is extremely required. And because not only for education but also in order to maintain the health condition, health status of female, especially at higher education and research education. So this was all about my presentation. I'm now opening the floor for question answer session. Thank you, sir. Thank you, everyone.
Okay, thanks a lot indeed. May I request the audience to have observations or questions, if any? maybe, I will ask one, I have one query, Dr. Bhanu Pritam and Dr. Kriti. You talk about financial assistance, right?
Yes, sir.
So, as far as financial assistance is concerned, have you examined educational loan? And if any, then how educational loan through banks and educational loan by government of Bihar?
Sir, it was just one of the limitations. I have studied only the financial assistance provided by UGC, universities, and CSIR, these institutions. Not exactly the educational loan, because my area of study fall under social science, arts, and humanities discipline. And there are very less chances of getting educational loan, and therefore I have studied only UGC fellowship, UGC scholarship, non-net scholarship, and some of the scholarship provided by the state government and university itself. So that was one of the limitations of my study.
Okay, thank you. Very interesting paper. So I hope that you will finalize your paper and submit for publication.
Thank
Thank
you.
you, Anu Pritam and Dr. Kriti. May I request the next participant to make the presentation by Ms. Varsha Gaur and Professor Naved Jamal. The topic is South to Capital, Lessons from the South for Transgender Education in Delhi. Over to Varsha Gaur. Around?
Online may not be there also. Will I have to check?
Also absent. They will move to the next presenter, Professor Pratibha Desai, and the title is a study of reproductive health problems of rural women. I understand that the data is from Tamil Nadu or Maharashtra. Maharashtra, yes. So we had interesting discussion in the while we were having breakfast. So let's listen, Professor Pratibha Desai. Madam, after 8 minutes or 7 minutes, it will start.
There is PPT, but I will summarize. No.
Yeah, and then 2-3 minutes is still left when ringing, so don't worry. You don't have to abruptly stop.
Okay.
Another 2 minutes.
Okay. Start.
Digital intervention.
Yes, we will start. No problem. So ये स्टार्ट करेंगे. नहीं हो तो मैं थोड़ा शुरू करती हूँ तो व्हाट्सएप पर भेजिए. मेल पर भी भेजिए. इंट्रोडक्शन दे सकते हैं. हाँ, इंट्रोडक्शन शुरू करेंगे जब तक पीपीटी शुरू होगा. रिस्पेक्टेड चेयरपर्सन, माय फेलो प्रेजेंटेशन and all of you. I'm myself, Dr. Pratibha Desai, from professor in the Department of Sociology, Shivaji University. And this presentation is entirely based on one of my ICSR project, that is the IMPRESS. And I have taken this topic, basically, it is the reproductive health, where either urban or rural women, there is the cultural silence concerned with the reproductive health. And particularly, I have focused on the reproductive problems, and I have conducted this project basically in the Western Maharashtra. Entire Maharashtra has been divided into 5 regions, and Western Maharashtra is the one of the region where Kolhapur, Sangli, Solapur, Pune districts are commander, and Satara one is that. And with these districts, earlier I have focused 2 districts. It was funded by the Women Commissions of Maharashtra State, and other 3 districts were focused with this IMPRESS project. So I thankful for ICSR for giving me this opportunity to that means conduct this research. And it is the project based on the empirical theories, where we have conducted the interviews of the 300 rural women and 300 urban women, but I have not taken here urban women. I have focused only on the rural women. We interact with them about the reproductive problems. But one thing I have seen, there is still cultural silence and women are not ready to give the answers about this, particularly the reproductive health problem. Just this is the small PPT and the study of the reproductive health problems of rural women. And just I think that these are the introductory parts. For example, what is the reproductive health? When the reproductive health becomes a public major discussions after the Cairo conference in 1924, and after that the discussions about the reproductive health come emerged. Huh? 94, ma'am. Sorry, 94. Yes, 94. And after that only the discussion was come and reproductive health or either reproductive right and reproductive health problems. Next. Is there a next one? Just entire my presentation is divided into the following points: reproductive health and rights, reproductive health of rural. Actually, this is not to be urban. I have focused only the rural women, reproductive rights and major reproductive health among the rural women, and review of literature is some part, and the research methodology and major findings and conclusions. Next. This is the introductory part. I will not go. All of you aware about what is the health and how health and gender is to be related and what are the functions of health basically and concern with healthcare and the women. Next. And this is also the introductory part. It is only that reproductive health concern. Next. See that concept of reproductive health, just ma'am says that it was the slip of tongue. It is not 1994. The Cairo conference has defined reproductive health as a condition in which the reproductive process is accomplished and complete with physical and social well-being. That means there are the social, physical and mental well-being with the reproductive process. Next, these are all the definition. Here is the World Health Organization is also given the definition. And in the reproductive right, actually, reproductive right also come after the Cairo conference, and a reproductive right in Indian context is to be the far away. It is not the reality where there are many decisions were taken by only family or their causes. In see that basically in Western Maharashtra, in prosperous states or districts of the Maharashtra, where we see the declining child sex ratio. So that is only one of the where women are not have right to keep or the that whatever the and they are to be facing the problem of the female infanticide. Next. And this is also the concepts. What is, we say that what is the reproductive right? And these are the definitions. So I think that this is not to be even next. Next. See that we have major reproductive health problems. International Conference of Population and Development, Cairo, has given the importance to the women's health, particularly the reproductive problems, and that after that reproductive problems, like for example, abnormal discharge, abnormal irregular vaginal bleeding, and these are the basic, very basic or very important reproductive health problems where even though not the family, but even though women are not ready to speak about their own problems. Next. These are, see that sexual transmitted disease, reproductive tract infections, and these are the very important reproductive morbidity where there is the contraceptive morbidity is to be the prevailing, but that is not to be permanent. Gynecological cancer. Next. This is the review of literature where many reproductive health problems are taken in consideration with medical instance, but they were not socio-cultural perspective otherwise and gender perspective. Next. See that my data is there. Next. This is the methodology where there were 4 villages were taken. From 4 villages, 25 respondents in the age group of 18 to 45 years, and they are to be the married women. Next. These are the some findings of my study, and this is the I have taken socio-economic conditions, their characteristics, and reproductive health problems they are suffering, and third one is the reproductive right awareness or some level of the exercise of the rights. So this is the age bar, and this is the weight where in weight concern there is the relations between weight and health. So in rural women the obesity is not to be the problem. Next. This one is the religion, And next one is to be the, please give the spect, that spect. Religion and marital status. Next. This one is the education, the education and number of the children. Next. Next. So plus, please, previous slide. This is the education of their and their partner's education. Overall, more women are the illiterate and their partner education is to be the better. Next one. This is to be the occupation, where in rural areas we see majority of the women are the housewives and the male are engaged in the agriculture or some private jobs. Next. This is the monthly income and this is the saving, where we see that they are the housewife. So majority of women say we have no income, but we see that in the saving, they are saving, their capacity is 100 rupees to 500 per month. Next, this one is the type of the houses. We have taken the type of houses and majorly number of rooms, because there is a relations between reproductive health and separate room for the couple. Next. This one is the, I think that the age of respondents, age at marriage for male and their the husband and wife's age marriage has been taken, where we see that below 18 years found among the females. Next. Next. Respondents, sir, shall I go there? Because it is not visible for me. Shall I go there?
Major findings?
Yes, I will give, but I have not, it is not visible for me from here.
Okay,
So,
no problem. So if you could summarize.
Use that mic.
ha,
She can use that mic. She can do that.
ha,
Take the mic.
ha. Just it is not visible. May also pack some. Okay, 1 minute. But just
Take your-
1, 2, 3 minutes. See that respondents, these are the health problems. Before first slide, please. First slide. First slide. Previous slide. Back. This one is to be the house type and the house is covered and number of the rooms in the houses. There is no problem of the room being in the rural area. And next one is, these are to be the respondents and partners age marriage. Next. Health problems. Here basically the health problems are just health problems. Initially we have taken the thyroid, BP, sugar and heart problems. But this is not the problem of the rural women. There is very less patients, less women suffering from this type of the disease. For example, thyroid. Next. These are the reproductive health problems, where I have taken white chest, vaginal odor, and pain and itching in the genital parts, and the pain while in the pelvis. Next. And this is also the pain during intercourse, where the extraction operation. Next. This is also the reproductive health problems. Next. And this is the infection while urinating, excessive bleeding, swelling, and uterus cancer. There is no cases of the uterus cancer. Next. So that awareness about reproductive health we have taken to spend the money, availability use of the healthcare facilities, and accompanying person with hospital, use of family planning and healthcare facilities at the pregnancy, and decision to spend the healthcare and place of pregnancy were taken. Next. This trailer, contribution way to dispose the clothes used to it. It's very bad to that. In rural area, still 40% of women are using the clothes, reusing the clothes. And there are 2 points, 2 reasons for this behind, because some taboos are there. That the family taboos are that they are preparing the clothes, they are not within these bags. And second one is that some are not having the purchasing capacity, or they don't want to spend money on this way. And next, this is the disposal is also one of the big problems. Next one is the respondent discussion to take safe sex and opinion about the consideration. This one is there. They say yes, but there is not there. There is while we are interacting with them, they say we will have safe sex. There is the consent of the partner is there or anything else. But if we saw that they are laughing and they are avoiding to give the answers. Next, a respondent discussion and next.
See that decision makers to be treatment during the pregnancy. From reproductive process, still from pregnancy to birth, there is to be many way processes. And where, in case of where to take the pregnancy, where to keep the pregnancy, relative to the pregnancy, what part of the treatment, where to go delivery, these all are to be taken by the family decisions. And many times rural women are not interfering. So that's why the child sex ratio is to be increasing. So while women themselves are very less, 90%, where fathers and in-laws or their husbands are taking the decision. See that it is the 51%. Next. A response pregnancy test, number of children, place of delivery. Next. When questions total majority give the answer yes, but it is not to be given. And when we are discussing about digital health is very important. Through the ASHA workers and community health workers, doctors or TV or this social media making the awareness about this. Next. And let's see that overall the conclusion of my study, the socio-economic characteristics of response, reproductive health problems and right of rural women have assessed by the available data. The study shows that the socio-economic characteristics such as the education status and economic and awareness about the health is below women, particularly rural women, and it is found that only 20% of the reproductive health problems for rural women are reported by, because women are not unaware of it, but there is the cultural silence and they are not ready to. And these problems are somewhat, so many times they are not to be identified. For example, urinating influenza, bleeding, excessive bleeding, like this. And still women are not speaking about these health problems. They are not ready to give these information. In case of reproductive rights, rural women are dependent either the spouses or in-laws, and non-availability of healthcare facilities near to the rural women affect their reproductive health. And the study shows that overall awareness among rural consumers is better because 50% they are to be near the city. So gender discrimination should be addressed, and women should allow exercising their rights. Because when we go for their houses and when we talk to them about the menstruation, because there are very many parameters. In my project, I have submitted the report, but I have taken some parameters because it is the presentation, and we discussed about this as that no, it is our personal problem, it is our private issue, and you should speak with me only. We will not allow to our children sit here or our husband sit here, and many times the in-laws are intervening them. They are thinking we were something taken the information for them. So I think that where we say the gender, the reproductive process is not only one process. It is the two-way process, and the male and female has to be involved in it. So it is better to create the awareness among other side, and the gender discrimination and social cultural issues in the particularly reproductive health. Because when we, that means we visited some clinic there, and the clinic patients, they say that no, this is their private data is concerned with reproductive health problem with us, but we will not give you. But women are not ready to say that I am suffering from like this, I am suffering from this. And new problems like, for example, post-delivery checkups, there is no awareness. And for example, the uterus cancer, excessive bleeding, for example, breast cancer, there are cases, but they are not to be reported. They are not ready to report it. So, 94 of the reproductive health become a we say that public issue, but still it is even in urban areas. It is not to be becoming an openly discussed issues because of the taboo. So both way, male and female involved this, then it will become very free or healthy reproductive health. And media plays an important role in this. Thank you. Thank you.
Thank you, Professor Pratima Desai. Any questions or observations? Yes.
Very quick. Any particular reason, ma'am, for not taking productive age group of 15 to 49 years as defined by LFHS, but to stick to 18 to 50? Any particular reason there?
Just for reasons, I think that 18 to 45, because marriage is to be known, particularly in rural areas. Marriage is 18 to 45 years. And I have
you sure there is marriage before 18 for girls?
No, girls, that why we say that what is the age of your marriage? I have taken the age group of 18 to 45 years, first thing for data collection. But when we asked what is the marriage of your age, and here women are from among the 45 years old, years are there, no? They got married at below 16, below 18 years also. That means that.
If teenage pregnancies and early marriage is still a problem, it makes more sense to broaden the reproductive age group rather than constrain.
Oh, but that married group I have focused because even married group they are not meeting. वो बोल ही नहीं रहे थे ना.
आप प्रतिभा बैठिए, आप बैठे. ये आपका पहला स्टडी है क्या?
नहीं.
आप बहुत कुछ टेक्निकल इसमें रिपेयर करना है. सॉरी, ये एक बहुत इम्पोर्टेंट क्वेश्चन है. हम जहाँ यहाँ करते हैं स्टडी तो उनकी एजेंट मैरिज जहाँ मिनिमम रहेगी. You have to start with that. You can't decide कि 18 से लूंगी. Because very important. NFS से डेटा देखें ना, 18 से पहले भी शादी हो रही है. You can't, आप चूज नहीं कर सकते. Don't choose. And plus, Mateen sahab should be. I mean, I don't know. Support me if I'm talking, right? That there are only linear tables again. Which women? How many women? Who are the women? What are the socioeconomic background who are suffering from this medical problem?
Sir, ma'am, I have got those cross tables, but I have not taken it yet.
Single table डालने से कोई फायदा नहीं.
Intersectional perspective, I think, is important.
That many I have crossed with age group, I have crossed with caste system, I have crossed with other categories, religion, to the health problems, but I have not taken here. I have taken only simple tables.
You always should rationalize.
Yes, okay.
18 to 45 क्यों दिया?
So married group का और actually
50 में भी तो
नहीं. They look मगर 18. We said that it is the 18 is to be the marriage age. No, if you ask the women, are you get married at 16, 14? They will not, because it is illegally only 18 years is allowed. No.
Are we going for legal?
18 years is allowed. So that's why 18 years के
because we are demographers, we should always go with the empirical reality, not with the government.
No, अगर हम उसको पूछ सकते हैं कि आप 18 से पहले मैरिज हुआ तो कोई डाटा नहीं देता. And 18 का ही
why others so aware of legal?
तो 18 year का parameter 18 year is the marriage of. So that's why
we are looking up our data.
18 to 45 years.
How really
Next
Thank you.
Thank you.
So I have one small observation. The point is that how the intervention of ASHAs and ANMs have contributed in the reproduction, not in terms of tables, because sometimes it conceals the reality. So my suggestion would be that with the help of few case studies, maybe 3-4 case studies.
Actually, what happens? I have completed a whole project, ma'am, major project, and I have that case studies also. ASHA workers case studies, community health, that ANM, or many the clinics also, but I have not added in this, and because their role is very important thing.
My observation is keeping in mind that we plan to publish.
I will add those.
थोड़ा सुनिए आपको क्या advice दे रहे हैं, please note down.
Yeah, we want to publish major articles, and within a month or two we expect the final draft. Maybe you can pass on the
yes,
probably
yes.
online.
No, that
microphone.
That mic.
Microphone. Yeah, because online participants will listen. The reason why I'm asking you that if some case studies could be also incorporated in your presentation, where because of the intervention of ASHAs and ANMs, how this reproduction process has got is improving. That will also give us some insights about the reproduction problems and also how interventions by ASHAs and ANMs have improved. That will be really very helpful.
Are there some gadgets? She was referring to some gadgets. Are they using ASHA workers?
I don't know that. You can tell us that ASHAs.
ASHA workers telephone क्या कोई देते हैं?
Yes.
I have also done one for
Yes, he's there. Telemedicine is there.
Okay. Can I have the telephones with it?
Yes, that some all of them are not, But some of them PSCs, they are provided the Android phones to feed the software data and to discuss with
You
them.
please focus on that in your paper.
Yes, I will focus.
The role of digitized,
Digitized. Okay. My other one was suggestion is that because I will remove these tables and I will add those tables that which shows the socio-economic characteristics and reproductive health.
No, in the paper you keep whatever suitable media and tables
that's
are there.
that.
But when you are talking about particularly decision-making power.
Thank you, Professor Pratima Desai, for very interesting presentation. Now I move to the next participant, Ms. Reshma Saman. The topic is understanding challenges and negotiations with digital health initiatives. A study on tribal women in Mayurbhanj district of Odisha. Over to Reshma Saman. As usual, after 7 minutes, it will start ringing. You don't have to stop abruptly, but once it will start ringing, within 2 minutes, wind up.
Sure, thank you. Good morning, all. First of all, I would like to thank the organizer for giving me the opportunity to present my paper in this 2 days international seminar. I'm delighted to be a part of this program. So, as you can see, the topic for my presentation is Understanding Challenges and Negotiations with Digital Health Initiatives, a study among tribal women in Mayurbhanj district of Odisha. So, in this paper, I'll be basically sharing the preliminary findings that I collected from my field work recently. So, first, I'll start with the overview of the topic. So I'll just quickly highlight the objectives, significance, and the needs of the study. So, the presentation is about the lives of next. The presentation is about the lives of tribal women in Mayurbhanj district of Odisha. The tribals or Adivasi who constitute 8.6% of the country's total population. In Odisha, there are 62 tribal groups which constitute 22.8% of the state's total population. And the field site that I have chosen is Mayurbhanj district of Odisha, which has the second largest tribal population as per the census 2011. So in the paper, I'll be basically touching upon how the tribal women negotiate with and perceive the state and digital state services that are available to them, including the health initiatives like National Digital Health Mission, Ayushman Bharat Digital Mission, Ayushman Bharat Health Account, which is also called AVA, e-Sanjeevani app, digital dispensaries, telemedicine, and other healthcare delivery systems. So particularly, I'm interested to know whether their adoption to those services are voluntary in nature or they are being compelled by any external compulsions. So also I'll be highlighting the challenges that they encounter in their everyday life while negotiating with those initiatives. So this was the core essence of the study that I'll be discussing throughout the paper. So now moving on to the significance of the study or the research gaps. So it's basically the study is important to understand how the tribal women are coping with the technological tools, especially mobile phones, and the services that are available to them in the evolving digital landscape. So especially the tribal women, they are at the receiving end. They're the most marginalized when it comes to accessing digital services. So several studies have examined various aspects of tribal life, its impact of digital technology on social, economic, and cultural aspects of their lives. But the study mainly lacks an ethnographic approach. Furthermore, there has been no systematic study on understanding how the tribal women, especially in the Mayurbhanj district of Odisha, where we see the women, they are the most, the tribal groups, the tribal population in Mayurbhanj are the more developed and advanced, compared to all the districts in Odisha. So the study also contributes to STS studies, which is science, technology, and society studies, feminist studies, and tribal studies, by exploring the intersection between technology, gender, and tribals. It will also assist the policy planners to implement digital initiatives in a more informed way, keeping in mind the real issues faced by the women at the ground level. Then moving on next. moving on to the literature part, I'll just skip it, but I'll just quickly highlight the major findings that has been drawn. So the studies have shown that how the digital tools, especially the mobile phones, can improve the maternal health in the developing world, how women use various technologies for health related purpose, mainly seeking health related information, seeking reassurance, managing uncertainty, and some of the barriers that they face, like infrastructural barriers, limited digital literacy, poor internet connectivity. Next. And then also how the DSTs, the digital health technologies, have a positive impact on improving women's health, empowerment, and gender equality by facilitating skill acquisition, health education, social interaction. So these are some of the findings that has been drawn. I mean, then I'll move to the objectives. Next. So there are two objectives for the presentation. So to examine how the tribal women in Moirvan's district, they negotiate with the digital tools and the services in their everyday lives, and the kind of challenges they face. Okay, I'll just start. So, I have used Judy Workman's feminist technoscience perspective to look at the complexity and dynamic nature of digital health initiatives and its significant impact on the woman. So, Workman, she is one of the main voices in the Academy on Technological Feminism. She has also published, several works. So one of her, two of her influential works include Techno-Feminism and Feminism Confronts Technology, which I have referred in for for this study. And she is also an important figure in STS studies. This perspective she mainly argues that how technology is gendered in nature. Technology is not something which is purely technical or neutral in nature. Rather, it is deeply embedded in socio-cultural factors. That means technology, she believes that it's like a social construct. So, how various socio-cultural and political factors influence the uses and access of technology among several categories of people. So then also by arguing this, it supports the idea that how technologies are designed and constructed in such a way that it is only accessible to those who are more privileged to have the benefits. Next. Huh. And then I'll move to the result and discussion part. So I have, so first is negotiation with digital health initiatives, where I have divided the section into three parts. One is awareness, uses, and access. So in terms of awareness, I'll be touching on like how the tribal women, to what extent they are aware of the existence and importance of the digital health initiatives. So the study has found that there are several health schemes that are available to them in the regions, and they are also aware of it, but some of them are not aware of the digital platforms that are linked to those services. So it has been also seen that women are mostly aware of digital health schemes or the services through the local community health workers, panchayat leaders, self-help groups, anganwadi teachers, and the asa workers. Some of them, they receive those ideas through social media platforms, like very few of them, YouTube, online platforms, and Twitter, like this. So then access, despite several awareness program, many women, they continue to struggle to access and interact with the digital health platforms. Next. Like limited digital infrastructure such as poor internet connectivity, electricity, mobile network, those often create physical barriers to accessing digital platforms. Lack of willingness, having fear in mind, doesn't allow them to own a personal phone and explore various digital health facilities that are available to them, which results in making them rely on their male partners or any like family members. Uses, now I'll move to the uses, like how they use those services, those digital tools. So some of them, even though some of them have access to digital health platforms, but it's challenging for them to navigate through these. They're not aware of, or they lack technical knowledge to navigate through this. And as we know that usage basically depends on individual confidence, trust in the digital medium, presence of the support structures. But where lack of technical knowledge, lack of willingness, fearful perceptions do not lead them to engage with the digital health platform, so they either approach the CSA centers or take the help of their family members. So now I'll move to the constraints, the challenges that they face to access digital health initiatives. So despite the implementation of several health policies and schemes in improving the healthcare delivery systems, they continue to face a range of structural, social, and political challenges that affects their negotiation with the digital health platforms. So the first, I'll start with the geographical location. Geographical location is one of the main barrier, because the tribals, they're mostly situated in remote areas, densely forested areas, where the infrastructure is very poor, like poor mobile network coverage, lack of internet connectivity, long distance from the market, and frequent electricity fluctuations are some of the reasons that restrict their access. Even to purchase a mobile phone also, they have to travel nearby, like 20-30 kilometers they have to travel. Infrastructural limitations, like primary health centers, hospitals, CSA centers are located in a distant places from their locations. And then community perception and prevailing social beliefs, which significantly influence how they perceive, how they accept those digital tools. The associated sociocultural beliefs and stereotypical ideas of male members towards women discourage them from actively participating in the digital platforms. And then financial constraints is another reason. Many women are unable to own personal mobile phones. They're often compelled to rely on their husbands or any of their family members. And also doing a monthly recharge is also difficult for them. So digital illiteracy and lack of technical confidence also pose a threat to their negotiation. So especially the older and the illiterate person, they finds it quite challenging. They are unable to perform even the basic health functionalities, like how to do online registration, teleconsultations, or seeking health related information. Privacy concern is another reason, because women, they often fear that using mobile for health apps or sharing any personal health information without having proper knowledge could lead to breaches of confidentiality or social stigma. And it also gets intensified due to cultural norms and social dynamics, where the digital activities are monitored or controlled by their husband or any of their family members. So and state compulsion is also there, because several state welfare schemes are digitally mediated, which has made the citizens compulsorily to adopt those services irrespective of their will. And without providing any proper training, awareness program, or support, it like kind of pushes the citizens to engage with the services. So there are a few narratives. Next. Okay. Next. So there are a few narratives that has drawn during the field work. And then next. So I'll conclude the presentation with a few important points. So the present study provides a comprehensive understanding of the interrelationship between technology, gender, and society. It highlighted how the tribal women's access uses appropriation, shaped by a range of social, cultural factors, identified some key constraints to women's limited association with digital health initiatives. Also, building on the theoretical framework that I used, Judy Workman's framework, it stated that how the technology is not how the technology is a social product, it's a social construct. It suggests that not merely implementing the policies will overthrow the inequalities, rather each dimensions need to be taken into consideration to enable women to be seen as socially and technologically empowered. So with this, I am concluding the presentation. Thank you.
Thank you for your presentation. My query is that have you completed your field study so far?
So no, sir. I just went for the preliminary fieldwork.
Okay.
This is my pilot.
Pilot.
Yes.
What is this, you have mentioned about sample size 60, 60.
Yes,
Did you?
60.
Yeah. How did you arrive at this magic number?
Because I was reaching individual respondents, so I calculated that the number was total 60.
Case studies you are not thinking of?
Probably in my next fieldwork I'll be doing that, but this time it was just a general interaction with those respondents. I mean, it was through snowball sampling technique, so that's it.
Okay, thank you. Any questions or observations? Yes.
Can we go ahead with the pilot study? And I found no percentages and numbers.
Yes.
Some
General
many,
comments.
some
General
Right.
comments are there.
authenticity of data. Why did you write few, many? You have to give exact number.
Numbers, it's
Table.
I have not analyzed those data.
Covered 60 numbers.
Number 60. Only tribal women. There are other categories also that I didn't mention. I'll be starting in the next month.
So, but 30 and you have to generalize that.
No,
60 and
60 is not the total number. That was, from the pilot study only. But I'll be starting the men fieldwork probably in the next month. So there
but
I'll
in
be.
pilot study, many questions will be deleted or added. No?
Yes, this is just one part of the research objective. So that was not the whole essence. So basically, I was asking them the digital initiatives, not not specifically on health initiatives. There are many. So I was trying to know what are the schemes, especially the schemes that are available to them and their way of negotiation with that. So digital health is one. Yes, it is not there because I have not done the analytical parts yet. So
I think Reshma, the problem is because you do pilot too quickly without really conceptualizing your problem. Even the pilot testing has to be done once the problem is well conceptualized, the methodology is clear, your sample is clear. Then you go for pilot testing. Pilot testing is not like देखते हैं field में बात कर पाएंगे. It's not pilot testing, right? So I think it's early pilot testing rather than going to the field next month. My suggestion would be take time to conceptualize the problem well. Be very clear about what initiatives you're going to focus on, who are the people, why, how can you arrive at a magic number of 60, 70, 80, 100, whatever it is it proportionate to the population? That's a good way of finding a number, especially if you're doing quant data. Quant data, of course, that will not be the logic, right? So take time to conceptualize your problem. PhD is the only time when you have liberty of time in your hand to actually spend time in conceptualizing the problem instead of you'll be juggling through multiple things. Right? So do that first before going to the physical.
sure, ma'am. Thank you.
Reshma, good presentation. I like your confidence, the way you have presented, because you have clearly mentioned that it is a pilot study.
Right.
Still long way to go. I just want to say that you told that the tribals were more advanced compared to other tribes. But do you have any data or just like a statement?
No.
Because
Yes.
there are 65 tribes are there. So in future, in your field work, take more time in the field. I think so that will be the good research. Thank you.
Thank you so much.
Thank you. Probably we are going for the last presenter today. Now we are going to have Dr. Shabana Kesar. The topic is digitally empowered women's psychological well-being and intimate partner violence. Over to Dr. Shabana Kesar.
Good morning, all of you. Respected Chairperson, Professor Abdul Mateen Sahab, and my presenters, and the august audience over here. I'm really thankful to Dr. Ziauddin and Shahada Madam, for including me in the last moment. Actually, my topic is somewhat related to the already project which I have submitted, minor research project which I had done on in intimate partner violence and its impact on the psychological well-being of women and the support system they get from the society. So, Madam requested me to, do some work on how these women are they using some digital platform also to address this issue. So, in the light of that, I have prepared some work on this related to my already which I have done the work. So here is my title. This is digitally empowered, addressing women's psychological well-being amidst intimate partner violence. First of all, we must understand what is intimate partner violence. As we all know that it has been defined as a behavior within which an intimate relationship that causes physical, sexual, or psychological harm, which remains very private, and it's not in a public platform, and it remains a very pervasive global issue. And according to the World Health Organization 2021, approximately 30 women, please go to the next slide, 30 women age 15 and older women experience IVP, that is intimate partner violence, with rates higher in low and middle income countries. Please go to the next slide. Yeah. Yes. So this is the global prevalence. Approximately 1 in 3 women, they experience globally IVB in their lifetime. And this is the WHO 2021's report. And there are also hidden scars. While we say that physical injuries are evident, but the psychological consequences like PTSD, anxiety, depression are often long-lasting and under-addressed issues. Well, I will be talking about them in the next this thing. So the objective of me doing this title was analyze the psychological consequences of IPV on women, including short and long-term mental health consequences, and assess the efficacy, accessibility, and the limitations of digital interventions in addressing IVP related to mental health needs, and also to propose a kind of trauma-informed, culturally sensitive, and inclusive framework for integrating digital tools into IVP support system. We have support system in the society, like NGOs are working for it, and many government organizations are also working to address the IVP women. But in spite of that, we should look and explore for digital platform also. So this was the one of the objective to look into this. So, talking about the psychological impact on women, it has a profound and multifaceted impact on women's mental health, and research has shown, which established a strong correlation between IVP and the mental health disorders with survivors experiencing. Number one is depression was the major concern, major issue the women were facing. Chronic feelings of hopelessness and worthlessness, often linked to prolonged exposure to abuse. Post-traumatic stress disorder, which we say PTSD, symptoms include flashbacks, hypervigilance, and avoidance behavior triggered by traumatic experiences. Then anxiety disorders, persistent fear and worry, often exacerbated by the abuser's control tactics. So, substance abuse used as a coping mechanism to manage the emotional pain, and suicidal tendencies. Many of the survivors or the effectors of IVP have this kind of tendency, suicidal tendencies also, and they have low esteem and isolation issues also, which they face when they go in the public platform. So let us see what are the barriers of seeking these support actually. So the number one is the stigma and the shame which is attached to IVP. Women generally don't open up talking about this IVP to even their own relatives, to their own parents, or to the family also. So they are very reluctant in this way. because our cultural norms, particularly in the patriarchal or conservative societies, often discourage women from disclosing abuse due to fear of any kind of judgment or retaliation. And there is also economic dependence, which is one of the major reason why women don't come out and speak about IVP. It is that financial resilience on abusers limits the access to paid services or even transportation to support these centers. And geographic barriers are also there. Rural and unreserved areas often lack trained mental health professionals or IVP specific services. And there are confidentiality concerns also, like the fear of breach of privacy, confidentiality, and especially in small communities where these women are very reluctant to speak about these issues. And there are systematic gaps also, whereas the overburdened healthcare systems are insufficient in funding these IVP programs, also limit the access to the support system to the survivors. So these barriers highlight the need for alternative solution, wherein we can talk about the digital, usage for women, because a woman going to a counselor may need financial assistance also. And nowadays we know that counseling therapy, especially for mental health related issues, is very costly going on for the women, and especially for the women who belong to an underrepresented community. So this rise of digital initiative interventions came from those needs. After the COVID-19 pandemic, which restricted physical mobility and access to in-person open services, catalyze the adoption of digital interventions to address the IVP support. And these tools include, like the slide is not changing. Please go to the next slide. Yeah, next. One more. Okay, next. Yes. So the digital interventions have been evolved after COVID-19, because we had all things relied on online social platforms. So here we could also find the support system for the IVP survivors also. Like there are many social mobile applications like My Plan, Bright Sky, and Aspire, which provide safety planning tools, legal resources, and emergency contact information. For example, My Plan helps users access to risk and create personalized safety plans. And there is online therapy platforms also, services like Talkspace, BetterHelp, Seven Cups offer trauma-informed counseling through secure remote platforms, making therapy very accessible to those unable to attend in-person sessions. One more major thing attached to this, why we are shifting to digital, is that many women, while going for counseling therapy, also feel that if anybody finds out about a woman going to a counseling center for therapy, is again, a victim of being blamed as having some mental issue. So these digital platform has evolved as a savior for them. So there are many helplines and chatbots also, and even the NGOs and government have launched WhatsApp-based helplines and AI-powered chatbots such as Chayan or Soul Medicine, which provides 24/7 support and resources to these women. And there are online communities also, forums and social media groups where women form a group having a common problem. So they form a group without revealing each other's identity, and the privacy is also maintained. At the same time, the problem is also addressed. Next. So the strength of these digital intervention is that they have offered several advantage to the IVP survivors. Number one is the anonymity and the discretion, like tools which are accessible via personal devices that allow women to seek help without fear of surveillance by the abusers or a critical factor in abusive environment. So they are very safe while using these digital tools. And 24/7 accessibility is there, that digital platforms provide round-the-clock support essential for crises that occur outside the traditional service. Now, for example, if we are in like the physical counselor is there, we cannot reach out to them 24/7, but these digital interventions provide 24/7 support to the survivors. And if you talk about the digital tools, it reached to the larger population at the same time, including those in remote and unreserved areas also at a very low cost. And emotional validation is also there. Online communities and the peer support forums create very safe spaces for survivors to share their experiences, and they feel validated. And there is no feeling of, isolation also at the same time. So they feel digitally, that's why my topic I changed a little bit to digitally empowered. Like the digital tools often emphasize over agency, allowing the survivors to control their engagement with the resources. It is in the hand of the survivor how to use those digital interventions rather than with the physical counselor's contact. So yes, there are many advantages of these digital intervention. At the same time, there are some limitations and risk also, which are attributed to these digital tools. Please go for the next slide. If you talk about the limitations, there is a digital divide, like access to smartphone. Every woman cannot have a smartphone. Reliable internet facilities. We know that most of the women, they don't use smartphone or they don't have the internet facility, and the digital literacy is also major issue. Every woman may not be, the survivor may not be having that kind of digital literacy, which remains very limited approach access to the all women, we may say that. And particularly for women who are in the low income group, like the UNESCO has already said that estimates that 43% of women in developing countries lack internet access. And also the other major reason is privacy and security risk. Abusers may monitor devices more smart than the survivors. The abusers are there. So they may monitor their devices, compromising the survivor's safety. And many apps lack robust encryption or secure data storage, which increase the risk of data breach. And there is lack of trauma-informed design. Some digital tools fail to account for survivors' emotional needs. At times, a woman needs emotional support also from the counselor, which cannot be, attained by the digital tools, because there will be no kind of attention given from the digital platform. So there is lack of attention from that sense. So there is no emotional connectivity with this counselor and the survivor. So this is also one of the limitation of the digital tools. And digital tools also often operate in isolation, which lack integration with offline services like shelters or legal aids. They are always open. Women can go there and they can solve their problems effectively. So these are the things that there are advantages, and at the same time there are some limitations also. Please go to the next slide. So what we recommend or what we can propose is that there should be trauma-informed. Yes, I just missed this. For this, I went for a pilot study. Please forgive me for this thing, because I've already done the major part of the research only on the psychological impact on the women. But for the digital intervention, I had to go for the pilot study, where I took only 30 women from that data, which I've already done regarding the digital interventions. And in that, we came to know that 78% of women accessed. Yes, 78 never accessed formal psychological support, and 60% use the digital platform for mental health information or the peer support. And the survivors valued anonymity but raised concerns about the emotional disconnect and the data safety. And this underscores the need or just access and also the robust emotional design and the trust building in the digital spaces. So for recommendations from my side, please go to the next slide. Is that we should develop a trauma-informed digital design which should prioritize emotional safety, user control, and avoid triggering any kind of content. Integrated digital offline services should also be there, which should be somewhat offline and should be somewhat online. So this should offer clear links to real world resources also, like shelters, legal aid, and counseling. Excuse me. And cultural and linguistic customization. Tools must respect the local languages and social norms for true accessibility. As we know that digital platforms are not language sensitive, so this is also we should make sensitive for languages also. It's okay. Digital literacy programs should be there so that women come to know about these interventions. With the help of these digital literacy programs, women may be effectively using these digital platforms. So with this, I conclude. Thank you so much.
Thank you, Dr. Shaban Desa. Anyone ask questions? I have one query. I missed your field study data and the time frame. Can you just tell us about it?
Yeah. It was actually 1 year of span. We had to submit the 1 year, but it was extended 3 more months. We can say 15 months. It was a minor research project.
Okay. Field study where? Space.
Yeah, it was in Hyderabad. Yeah, I conducted research on 2 NGOs, Shahi, My Choice Foundation, and 2 of the government sanctuary. So the survivors the sample was taken from there.
Yeah, open for observations, questions. Yeah, ladies first and then.
No, I think it's okay.
So first one.
Very quickly, a very important topic indeed. I was just thinking that when you're talking about digital interventions, right? Rather than a specific apps, a specific platform, the fact that there's a mobile technology in hand, it's itself a digital intervention, right? The device itself. The irony of the matter is that the moment domestic violence happens, the first thing that victims face is the device being taken away. Right? Women being locked up and device being taken away are the 2 most common sort of treatment that is meted out to domestic violence victims by the perpetrators. Right? So in that case, then the question of sort of accessing platforms, what happens when they are there, the nature of the role on platforms, it becomes a secondary question rather than a primary question. Right? So maybe an important tool is to first look at what really happens at that moment. Remember, many domestic violence victims may be in such a bad position that they may not be aware of it, second, even if they are aware, they may not be able to access it for the reasons you outlined very rightly. But the technology itself being taken away is a very critical component in digital interventions. In older times, it was akin to कि लोगों को घर से बाहर नहीं जाने देंगे ताकि वो neighbors का support ना ले पाए, community का support ना ले पाए.
allow भी नहीं करेंगे उसको use.
So please account for that. I think that would be crucial. That would add a much needed dimension to your research. Thank you.
Yeah, next one. Yeah, Dr. Nayak.
Good presentation, madam. Little bit I confused. In one slide you wrote about 78% are never used, and other side you said that 60% they are accessible to digital, because digital means here I am also little bit confused about the TV serial or the mobile, and third thing about that dial 100 or 110 accessible or not. Because that is the first thing when we talk about the women's safety or partner violence.
Yeah. No, as I said, it was a public study only. Wherein, as I said, most of the women have not used those digital interventions. They are not aware of it. I'm sorry, I have having some throat issue also. So that was.
It is Hyderabad.
Yeah, but
Hyderabad.
yes.
If it is a tribal, they are not aware, then we are right. But it is Hyderabad. If Hyderabad people are not aware.
No, sir. When you ask a woman survivor,
But
their situation is very different. Actually, what Madam said, I would agree with her. The first thing is that their mobiles are being taken away. They are not, they don't have the access of their own. Some women, they don't have their own mobile also. So in that cases, using this digital interventions is really difficult for them. So they rely on the society much more than these digital platforms.
But I was suggesting that an integrated kind of support system should be available for the women, like in case if women is not able to go to the physical counselor, there should be some alternatives available for her in the digital space. So that was my only concern.
Digital concern, but many ma'am has also told that they are not allowed. I see that many of them have not phone also. So I want to, in your pilot study, you mentioned whether they are using which device or not using which device, whether they are to be contacting neighbors also. That is important because many people we have conducted one Saki one-stop centers, the toll-free number. But many of them don't know that toll-free number. Either we have to call for toll-free number, but we have to not the phones. That is very important. You have to clear that point, and after that.
As I said, that digital literacy is not there among the women of these class, where they are, at the hand of the abuser, the perpetuators. So digital literacy is a kind of challenge for them to avail these services. So this is one of the biggest challenge they face.
Okay, ma'am. So, very good presentation, all of you. But a small experience from my side is there should be a combination of both digital as well as the usual mechanical way of calling for help. If there is a specific number only for domestic violence, even if somebody writes on pen, paper and drops it, the finder can still call and say this has come from here. Because it's important that we cannot lose track of pen and paper just because only digital, only digital. So there should be a human in the loop. I always say, don't depend only on technology. There should be a people and they should be aware. In Portugal, it happened during COVID time. Even when they went for contraception, they surreptitiously wrote a number and kept. And that called for the help for domestic violence because they couldn't talk. They could go around, but then the people literally dragged their wives around whenever. But then the very fact that they wrote that number, the help was sent to their places. So that's one thing. And secondly, I wanted to say that no matter what you said, there is a discretion when you give your data. It doesn't happen like that. In US, a 17-year-old lady had purchased a pregnancy test, only the pregnancy test. But somehow they got to know of her results. And they sent a baby startup kit to the home when parents are not even aware of her pregnancy. She was going to abort. But the question is privacy, like for women, it is totally not a privacy at all when you give your data. So I just wanted to flag it. Thank you.
In this case, madam, in this case, many women I have seen, even though that education, they don't want to talk about this and they don't want to say that it is the domestic violence I have to report. This is also one of the constraints where we have to report it because there is the stigma. They are not ready to, even though in many educated women who is lawyer, who is the district collector, these are the Supreme Court same problem, but they don't want to say that this type is happening in my home, particularly.
I would like to just add that women need to be strong both internally and externally. I have my own doubts. Right. How many of the females here do not know swimming? Basic life skills to protect ourselves and also protect others, particularly females, also males, but particularly females since we are talking in that context, swimming, car driving, and one martial art. And there are 110 approximately more than the Government of India Act, both gender specific and gender neutral. Gender specific, Madam was mentioning Domestic Violence Act, and we have one more act to protect it, what we say, that POSH, POSH, at workplace. Then why should females, they are equally qualified and educated also. So why to bother? Why to fear it all? But martial art is important. You can display even in the house also, if need be, not just like that. Even at the workplace also, this is my thing. Another thing, one Government of India thinks that
Absolutely, absolutely.
Like saying men will continue domestic violence, women become strong and
I'm not saying that.
This is like men will do sexual harassment, women will
I'm not saying that.
like this.
I'm not saying. Absolutely.
As women, we know women in the room will buy this idea.
Then why are you doing this conduct seminar
Men
at all?
need to learn to behave themselves. No.
That's okay. No.
This is about the cultural shift.
Yeah, can we have any more observations, please? You want to say something? Okay.
I think you have answered that, but I wanted to know whether you have seen the socioeconomic strata within that your particular study, because it was not reflected in it. Because if you look at the digital skills and digital awareness, it will be vary across the sections. It will vary across the caste. It will vary across the community, class. So this is not done. We cannot say that digital inclusivity should be like that or should be like that. There are many complex issues which is actually prevailing in the society. So that's what.
Yeah. Actually, I had.
When we talk about social transformation, it is always the onus is on women that they do this. Where is their agency? So the question of agency becomes very important, and I think, in 21st century, we should talk about this agency and give that choice, because whether she wants to learn, it's her choice. Swimming, she wants to go for driving, that's her choice. The circumstances are very different. And again, defining her circumstances, I think the whole idea of this digital in politics of gender, what Amir had made clear very yesterday, is this, and we have to discuss this. That becomes very important. Thank you.
In fact, I also wanted to add, and if Dr. Sabana can reflect, because the entire idea of normalizing, whether it's intimate partner violence or any violence, has been historically evident in every human society. Human means men society. So, how do you see that, the whole process of normalization is there different in different social strata? In your field through NGOs, did you find that any kind of dominant narratives coming up? And do they have any alternate mechanism that, that can bring those narratives into public discourse, and, something can take place through the agency, what Professor Arvinder is referring?
Talking about normalizing this domestic violence is very true. Like when women go with these issues, first they go to their, in the immediate relatives. So they don't support her. They say you have to adjust, you have to compromise. No, the family will always try to save her marriage, because once a woman steps out and think about filing some case against her husband, again it will risk her to break up that family. So the parents are mostly worried कि भाई हमारी बच्चियों की शादी ना टूट जाए. So they always try to counsel them to just try, keep on adjusting, go for one more year. You'll have a child, and he may stop abusing you, or he may stop beating you. Then if you have a boy, that again that is luring her to keep quiet. So these are the things. First, after facing so many things, women think twice, more than twice, to step out and go for some counseling. So that is, I think, the last step where women resort to these, centers or support agencies and go and seek the counseling, because it affects their mental health. Because psychological, what this domestic violence is not just only physical, it is more than that, is mental well-being. So the women doesn't even she doesn't understand that I'm facing some kind of mental issue. There are sleeping disorders, there are trauma attacks to her, but she tries to manage with this all till the last end. And at the last, when it take a troll to her own family, to her own health, to her own children, then she decides to step out. And I think that is very, very, challenging for women. And we should, salute those women who think about, reporting these issues, because after very challenging, they go to those support agencies. So digital intervention is not the last step where to go, but it can just add on to those services. That's it.
I guess, of course, I had to intervene last moment. You might not have done the role of digital contributions,
reducing this pain, whatever. Now that we have an interface type of NGOs are involved, since we want to bring out a detailed papers on that, some more authenticity in the sense you have 60 women you have interviewed. Okay, so as she asked you, you have all socioeconomic background of this women. And yeah, and these NGOs, I know, my choices and all of them are quite aware of things. Digital knowledge is there with them. Have they tried to help them out? Yeah. Hmm. Hmm. Yeah, please do that. That is very important. And second thing I was thinking of, you have to raise the issue of, as I told you, we do not have one-stop center at the area where you have worked. We don't have, sir, there. One-stop center is really very good, where the victims, survivors approach intervention. There is nothing in the old city, the old packet land, we don't have. In whole of Hyderabad, there is one in Begumpet. Can you imagine? And government claims of, women's help groups and this and that. But when you see empirically, we lack the basic needs, where to go, what to do. So since I'm also dealing with it, it is very, very important that women are with socioeconomic background, you please try to complete it fast. That is, yeah, thank you.
Okay, yeah, thank you, Dr. Shabana Kosa, for making very interesting observation on Dr. Nayak's wondering that, about the non-access to, sometimes we get very weird data, and I will share one very weird kind of data that even in a city like Toronto, which is highly cosmopolitan at the global level, the woman was not allowed to open a bank account. I mean, in India, even in rural areas, you go and women will have bank accounts. But in a city like Toronto, in Canada, the woman was not allowed to open an account. She would work hard, earn, and give money to husband, and husband will keep it in the bank account as such. So we have very weird kind of data. I'm sorry that we are having lots of time constraint. We had very interesting presentations. We had data from Jammu and Kashmir to Maharashtra, Bihar, Orissa, and Madhya Pradesh, Hyderabad. Very interesting and thought-provoking presentations. Thank you all for your active participation. Since because of the time constraint, I wind up and hand it over to the organizer.
Thank you, sir. As we come to the close of this thought-provoking session, first and foremost, I extend my heartfelt gratitude to our chair, Professor Mateen sir, our speakers and audience for your valuable and thoughtful questions. So now it's time for facilitate our guest and chair. I request Dr. Zia sir to please facilitate our chair, sir. Now I request Dr. Zia sir, please facilitate Shabana Kassar ma'am with shawl and certificate. Now I request Dr. Bhavik sir, please facilitate Pratibha Desai ma'am. Now I request Dr. Zia sir, please facilitate our young scholar, Reshma Suma. Thank you once again. Now it's time for tea break.